Welcome. We are delighted to present this series of educational videos, Pituitary 101, featuring Dr. Blevins, a program exclusively produced by Pituitary World News with important information about the systems that drive pituitary function and, importantly, how those systems are affected by pituitary disease. Here's Dr. Blevins.
Hello and welcome back. This is episode 8 of Pituitary 101, and we'll be discussing the growth hormone axis so that you can learn more about this particular situation and how we interpret laboratory test results in patients with pituitary diseases. Let's start with this slide that basically shows you the brain, as usual for all of these axes, is involved in the regulation of this particular hormone system. I mentioned with prolactin that it was one of two systems where the predominant regulation of the brain in the hypothalamus was negative or inhibitory. This growth hormone axis is the same. In this particular situation, somatostatin plays the predominant role in inhibiting growth hormone release from the pituitary gland. Growth hormone releasing hormone does stimulate, it's just that somatostatin makes sure that you don't overstimulate the system. So growth hormone releasing hormone from the hypothalamus, somatostatin from the hypothalamus, the balance between the two regulates growth hormone secretion from the pituitary gland. Another protein hormone that's modified after it's transcribed from DNA. Growth hormone circulates in the bloodstream bound to different proteins and finds its receptor on tissues where it's internalized into cells and does certain things in different body tissues. One of the important things that it does in the liver is it leads to the production of IGF-1. And IGF-1, or insulin-like growth factor 1, is the mediator, if you will, of growth hormone action. Growth hormone has its direct effect on tissues, but IGF-1 has most of the effect that we attribute to growth hormone action in the body. Growth hormone also has receptors in somatic tissues and can lead to local IGF-1 production in cartilage cells, other body tissues as well. It causes salt and water retention in the kidneys, so it does have direct effects. There are negative feedback loops here as well. We know that IGF-1 suppresses growth hormone secretion. No surprise there, classic negative feedback. It also suppresses growth hormone releasing hormone and may actually attenuate somatostatin release to help increase that inhibitory factor. There are lots of stimulators of growth hormone secretion that have been detected over the years. Exercise is an important one in children. Growth hormone releasing hormone and ghrelin are some peptides that have been looked at clinically and commercially to see if we could use to treat some patients. And then there are a number of different inhibitors as well of growth hormone secretion. Important ones that I would point out are somatostatin, which we use to treat acromegaly. But you also see here in this list oxytocin, which some patients want to take for mood disorders and emotional distance with their pituitary disease. So oxytocin might actually be a negative effect on growth hormone release in those particular patients. This system is complex. It varies with age. It seems to undergo a decrease in activity as we get older, but the negative feedback mechanisms still play a role. An example of negative feedback would be if I gave someone too much growth hormone, their IGF-1 level would go up and it would suppress GHRH and growth hormone endogenous production. That would be if it's a person who comes in off the street and says, hey, I want to enter a trial. Let's see if you give me, what happens if you give me too much growth hormone. In patients that have growth hormone resistance, you can see elevated growth hormone levels below IGF-1 levels, and those conditions do exist as well. Patients with hypothalamic pituitary disease that don't make enough growth hormone usually see a fall in their IGF-1 levels. This slide is important. It helps you, it shows you what I had alluded to before about some of these hormones, and I think I mentioned growth hormone in an earlier episode, that it's a nictohemeral variation. It's secreted mostly when we're asleep at night. That's when our body's resting and rejuvenating, so it makes sense we would make most of our growth hormone while we're sleeping. The growth hormone levels during most normal adults are lower in the evening and certainly during the daytime. You can see here that these are the average levels. These aren't the actual pulses, but you can see that levels do rise and fall. And again, as I mentioned earlier, if you check growth hormone levels here, you get 0. Here you might get a 4. If you checked it over here, you're going to get an 8. And patients often ask, why is my growth hormone level so variable? Well, it's because sometimes during the daytime, more so in women than men, we can catch your growth hormone during a pulse. But again, all these hormones are pulsatile. Some of them are secreted mostly at night, and we have to be careful interpreting pituitary hormone levels by themselves. We have to use the target organ hormone levels too. So this slide shows us what happens with IGF-1 levels over time. You can see here this ranges from age 10 to age 90 on the bottom. This darker line in the middle is the IGF-1 level. That is sort of the average level. The lower line is the lower limit of normal, and the upper line is the upper limit of normal. And you can see during adolescence and late childhood, levels are really high, and they decline as growth is completed. But then there is a significant level of IGF-1 and growth hormone secretion that maintains that during adulthood, because growth hormone is an important metabolic hormone that does a lot of important things in our body. And then as you get older, sort of late 60s, early 70s, levels fall significantly. We keep these normal levels or this normal range in mind as we treat patients with growth hormone, especially those that are older and as they are aging. So this is the important thing that we use as a tool to assess whether growth hormone is produced in excess or deficiency. When it comes to testing for growth hormone deficiency, the IGF-1 level itself is only about 75% accurate, so we need something better to be able to assess growth hormone function. And what we tend to use in this setting is we stimulate the pituitary to see if we can lead to more growth hormone production, because if we can lead to more production, that tells us that the patient has an adequate pituitary function and secretion of growth hormone. The best test, well, there's no best test. This is like what I was saying in episode 2. There's really no perfect test, but the most commonly used test would be the glucagon stimulation test, where we give an injection of glucagon. For unclear reasons, it stimulates growth hormone release, and we can measure that response and decide whether a patient's normal or abnormal. Insulin-induced hypoglycemia is a gold standard test, but we don't do that often because it's a dangerous test and can precipitate heart attacks or seizures in elderly people or people with neurological conditions. So we tend to sway away from that and do the glucagon stimulation test in conjunction with the IGF-1. This is another one of those situations I was talking about in episode 2, where we have to look at the clinical history and the radiology to determine the pre-test probability of disease, especially when we're looking at IGF-1 levels. I get referred patients every month who have a high IGF-1 level but have no symptoms of acromegaly and have a normal growth hormone level and no evidence of a tumor anywhere. So we have to look at that clinical context to be able to say it's probably not a problem. We can do a test to evaluate them further. Same thing is true of low IGF-1 levels. So if we see a low IGF-1 level in an overweight person, it's probably not pituitary disease, but we look for evidence of a pituitary tumor and do a stimulation test to see if they have a problem. So you have to use your pretest probability to interpret these results, and that pretest probability is informed by the clinical situation of the patient. For most stimulation tests, we now accept that a growth hormone level greater than 3 is considered normal. I will argue that purely normal people often go to higher than 10, and I think that we probably, using a cutoff of 3, underdiagnose this condition and don't treat people that should be treated in some cases. However, the insurance companies and the FDA and pharmaceutical companies use a cutoff of 3, so it often doesn't matter what I think, and it's too expensive for patients to afford. And we usually, in our practice, stick to the guidelines as gospel, if you will, because we want to not treat patients who don't meet the official criteria recognized by the societies for therapy. The biggest controversial area in this arena today is growth hormone levels greater than 1 are considered normal in people with a BMI of over 25. This is going to be a man who's maybe 5'10" and 178 pounds or higher. you'd have to use this cutoff instead of this one. I think this is an unfair cutoff for people who are a little overweight, who have known pituitary disease, because the pretest probability is so high. And in that setting, Bayesian theory and statistics would tell me that I need to use this cutoff and not this one. I think this cutoff works if you have an obese person who doesn't have pituitary disease, had a low normal IGF-1, underwent testing, and if they're over 1, they're normal even if they're under 3. So unfortunately, insurance companies are holding us to this standard now, but I hope to change that over the next couple of years by intervening on behalf of my patients. The interesting thing is 40% of people with growth hormone deficiency have a cutoff over, or their BMI is over 25, so you'd have to use this cutoff. And you wouldn't treat those people probably, because many of them are going to have a level between 1 and 3. So I think we need to revise that according to the pretest probability. When it comes to testing for growth hormone excess, I'll show you two slides here. This first slide shows you the IGF-1 levels, standard deviation, where anything above 2 is considered high, and that most people with acromegaly have high levels. These are people who had macroadenomas and microadenomas, just all comers, and you saw that there was a little bit of overlap. A few people were close to 2. And then there are people out in the community who have elevated IGF-1 levels but no proven acromegaly, and I think these are the people that are 2.5% of the normal population are going to have a high level but be normal, and 2.5% are going to have a low level but be normal. So I think when it comes to testing for acromegaly, IGF-1 is a great test in the right clinical syndrome. Is there a pituitary tumor? Yes, then you can really rely on this result, especially if the patient has symptoms and signs of acromegaly. But in these patients where there's no symptoms and signs, you might do what's called a glucose suppression test, and that's what this test is here. We can give oral glucose to a patient, and then in a normal person, we will suppress their growth hormone levels. In this population of people who have elevated IGF-1 but no proven acromegaly, most will go to under 1.0. So some people use a cutoff of 1.0. I like to use a cutoff of 0.4. So if a patient goes to under 0.4, they definitely don't have acromegaly. If they're between 1 and 0.4, they might have it. If the pituitary scan's negative, you follow them. If the scan shows a tumor, you can diagnose it, because you can see that some people with acromegaly do suppress. Most people with initial acromegaly with no prior treatment they'll have a level that'll stay above 0.4. Occasional people, after removal of some of their tumors, they will suppress to under 0.4. So we can use this combination of tests, IGF-1 and a glucose suppression test, to evaluate patients. But again, it's in the right clinical context, and you have to know whether or not the patient has symptoms and signs of acromegaly and a pituitary tumor. In summary, the growth hormone IGF-1 axis, if you want to call it that, it's very important. It's the first axis that's lost in people who are developing pituitary disease, and we can use a combination of the IGF-1 and, if necessary, the glucagon stimulation test, or the IGF-1 and the glucose suppression test, whether we're sorting out for growth hormone deficiency or acromegaly in patients with pituitary diseases. Well, that concludes this episode of Pituitary 101. It's the last in the series. I hope that you've enjoyed it and have been able to get something out of this and understand your pituitary and how we test for its function, and the importance of combining laboratory data with an assessment of the function of the hypothalamic pituitary unit, and understanding of the limitations of laboratory testing and the little caveats about interpretation of those, and also the importance of looking at pretest probability of disease based on whether you have a tumor and symptoms and signs versus simply symptoms and signs that don't match with anything else. Once again, I'm Dr. Louis Blevins of Pituitary World News. Thanks for listening. Check out our website for regular reports of different things of importance that matter to patients with pituitary disease. You can see other videos on YouTube and listen to our podcasts, our radio show, and read our articles related to all things covering the vast amount of information available for patients, not only with pituitary disease, but with healthcare issues in general. Have a great rest of your day.
This is Jorge Fascinetti, co-founder and chairman. Pituitary World News is dedicated to produce content that informs and educates. We are a non-profit organization and as such rely on contributions to fund all these initiatives. We have exciting plans for 2025. If you'd like to learn more about our plans and help, please visit pituitaryworldnews.org and click on the donate button. Every contribution helps, no matter the size. You can also help by sharing all the information available on the Pituitary World News website at pituitaryworldnews.org. We welcome your comments and suggestions. Thank you, and thank you very much for watching.